The final 15 minutes. The €4 perfect anesthetic. What I want to do in the next 15 minutes is examine how, getting the most out of your automated low flow anesthesia machine requires a thorough understanding of each piece of the low flow puzzle and how they fit together. You need to know something about agent usage, something about CO2 absorbent usage, something about how your machine works, and you need to know something about target optimization, something about the effect of age, washing rates, opioid synergy, nitrous oxide additivity, permissive nitrogen accumulation, coasting, and a few other things. So don't ask what your machine can do for you, but ask what you can do for your anesthesia machine. So I'm going to give an example of how I have been managing several anesthetics over the last 3 weeks with automated target control low flow. And this was with the Flow Eye, and I will show you what the resulting cost was. I want to point out that the principles that I'm going to outline apply to all anesthesia machines. So let me take you to the operating room here, and this is the walk I take every day all the way to the left, room 11. And when I come in my operating room, and this here it will be the time, and this is how I will be managing my drugs. First thing I do after having applied monitors and established an IV is give an opioid. For example, 15 micrograms of sulfentanyl. Because I know it takes 2.5 to 4 minutes before the opioids have their peak effect. Ricaret has talked about this in the past repeatedly at NAVAT. And then you have to apply one of the most difficult techniques in our profession, it's weight. So you have to consider the oxygen concentrations that Professor Hedenstierna talked about. Maybe you can give antibiotics, but you wait. And then you give 2 milligrams of propofol, because sulfentanyl now is at its peak effect, and rocuronium, and you do some more waiting. It's very important not to switch on the vaporizer prior to securing the airway, because this will just result in waste and pollution. In 3 minutes, you will use at least double the amount of agent you'll be using during the entire case I'm about to show. For example, if you use 8 liters per minute phase gas flow with 4% sevoflurane for 3 minutes, you'll be using 960 milliliters of sevoflurane vapor, or about 5.3 milliliters of liquid. So remember this number, 5.3. Use some leftover propofol if you think your patient needs it. Then you're going to secure the airway, start the ventilation, and you're going to select your target. You enter the patient's age, because that's a covariate, we know it affects MAC. You select your agent, in this case sevoflurane, and you're going to automated gas control. And then, of course, we're going to use nitrous oxide. We select here because it's the least soluble, fastest, reliable agent we have, with few cardiopulmonary side effects, with a second gas effect that's more pronounced than previously assumed, as Philip told us, and all the other things Philip has been telling us about, like better oxygenation with nitrous oxide oxygen mixtures than with nitrogen oxygen mixtures. In addition, and I think this is from May this year, very recent in anesthesiology, it's becoming clear that concern about severe PONV does not appear to be a valid reason to avoid nitrous oxide. The increased risk is essentially eliminated by antiemetic drug prophylaxis. More details to be found on the right side there, Philip. Next, we're going to choose our target inspired oxygen concentration, and we're going to keep Dr. Hedenstierna's lecture in the back of our mind. We'll give 40%. And then, of course, I'm going to have to add nitrous oxide. So let's say we have this 40-year-old patient, and I want to give 1 MAC. Of course, I know that as my patient gets older, MAC decreases. So let's say my patient is 40 years old, and I want to give 1 MAC. If I would not be using any nitrous oxide, but the target I would be entering in my machine would be 1.8% sevoflurane, but because I'm associating 50 to 67% of nitrous oxide, my target end-tidal sevoflurane concentration will be something like around 0.7 to 1%. And together this will give me 1 mag. Now the nice thing, of course, why 1 mag? So why 1 mag? Then we have to go back to Ricard's lectures over the last few years and say a word about isobols. This is the fentanyl concentration in the blood in nanograms per milliliter. This is the end expired concentration of sevoflurane. And this is the target you're going to have to dial into your anesthesia machine. This deep blue line here are all the possible combinations of sevoflurane and fentanyl that make sure that more than 95% of the patients are unconscious. This dark green line here are all the possible combinations of sevoflurane and fentanyl that make sure that 95% of the patients will not move after incision without muscle relaxants. And this red line here are all the possible combinations of sevoflurane and fentanyl that make sure that 95% of the patients do not develop hypertension and tachycardia. So I said I'm going to choose 1 mag. Well, if I choose 1 mag in a 40-year-old, I end up with 2%. So that 2% end expired sevoflurane. But I'm also going to give 100 micrograms of fentanyl or 10-15 micrograms of sufentanil, which will give me a plasma concentration of about 2 nanograms per milliliter fentanyl, or the equivalent thereof with sufentanil. This will bring me right here. So with this particular combination, there is more than 95% chance that there will be no hypertension and tachycardia on incision. My patient will not move. I'm way above the movement, 95% movement isobol, and certainly my patient will be unconscious. But of course, I'm going to divide the 1 mag into 50 to 55% of nitrous oxide, and then here is my 1%. These were the numbers that I picked up when I showed you this graph right here. Now, the nice thing is that if you enter this covariate here, age, that all this information is actually contained in this device here. If I increase my target concentration here, you will see that the machine will automatically give me the total mag of the nitrous oxide and the end-tidal here. And in my patients, actually, I use 1.1 mag, 40% FiO2, and a speed of 2. You can also select the rate of rise. So most often, I use a speed of 2. So we're all set now. I'm entering my targets. I define my targets. And as I mentioned, there is no need to go to my target 1.1 mag really, really fast. Michel Strauss talked about it a year ago. Mira von Thiele will be presenting an abstract at the ISAP meeting in Chicago a few weeks from now, and I'm sure this will be a topic at the next NAVAT meeting. The importance of the relative importance of the rate of rise. Clearly, there's a lot of research to be done in this area. Anyhow, with a speed of 2 and a target of 1.1, you can see that with the you can see the following. First of all, the machine prioritizes the oxygen concentration. So you see a virtual step change. There's no exponential wash in to the target 40% of oxygen. It's almost a step change. And this has to do with the way the machine works. The result, of course, is that because the target inspired oxygen concentration is reached so fast, the nitrous oxide concentration will also rise very fast. So in just no time, you're up to 0.5 mag. And then it's perfectly acceptable to let the end-tidal sevoflurane rise a bit slower. When you look at this, you're going to 0.5 mag right away, and after 5 minutes, you're already up to 0.75 mag. And this is actually the fresh gas flow pattern. So that's one of the nice things of using nitrous oxide. Here, you get to the mag really fast, and you have a little more time even to, you can actually decrease the end-tidal sevoflurane concentrations you need, and it's okay to have it rise a little bit slower. You see that the fresh gas flow here will be progressively decreased, And you will notice the following when you've been giving anesthesia for a little while. So this is your end-tidal gas monitor. You get your end expired concentrations of CO2, oxygen, sevoflurane, and nitrous oxide. Let's look at these in a little bit more detail. If I add up all these numbers here, I only come up to 94%. So there's 6% missing. So what might this be? Well, it's called the balance gas. To get to 100%, you need another 6%. And what this is probably nitrogen. These gases we measure using infrared. Oxygen is measured using paramagnetic technology, but there's a series of molecules that are symmetric, other than oxygen, that we cannot measure. So this is 6% of nitrogen probably. And it's actually okay to let it rise. I think it's important to let it rise because it allows you to use really low phase gas flows. And this is how, and these are data from Robrecht de Metz here, still need to be published. You can see that over time, the nitrogen will rise slowly over 60 minutes to 10%, but that's okay. Leave it be. The only thing you have to realize is that it will come at the expense of a tiny little bit of nitrogen. You see you have about 58% here, and because the nitrogen rises to 8 to 10%, it will come at the expense of the nitrous oxide, but this is only 10%, so that's about 0.1 Mach. That's why I intentionally chose to use 1.1 Mach, because I knew that the nitrogen was going to rise. But if you leave the nitrogen be, then there is no need to flush the system, and you don't waste extra gases. And we'll see what the implications are with regard to agent usage. During the maintenance phase, you want to have a machine, of course, that uses really low phase gas flows. And again, here after 15 minutes, the phase gas flow has already gone down to 0.3 to 0.4 liters per minute. It is important to realize that your machine sets the target for your inhaled anesthetic and carrier gases right here. So that keeps you on this line. But of course, there's this other drug that's floating around, and that is fentanyl. And this, of course, will change the concentration. It will decrease. And you have to, if you're not using a continuous infusion, you have to top it up. So you have to also take this into account. This you can measure, but the fentanyl, what you do, how do you manage that? Well, you can use a TCI pump, you can use the Smart Pilot, or you can use an iPhone app if you're using fentanyl. There's a program by Thomas Schneider, it's called Fantasim. It's a great tool, and you can download it for free. And this would actually allow you to manage this part of the isobologram for inhaled anesthetics if you're using fentanyl. So, during the maintenance phase, it's also important to realize that it is okay to let the inspired CO2 rise a little, 2.5 to, which is 3 to 4 millimeters of mercury. I occasionally let it go up a bit further, and this will significantly increase the canister life. You have to realize that the effect of inspired CO2 on the end expired CO2 is mostly additive. Again, this has been extensively covered in past lectures of NAVAT. So the effect is additive, so it's okay to let the end tidal rise by 3 to 4 millimeters of mercury, or 0.5%. This is the phase gas flow of the flow eye, progressively decreasing phase gas flow, exponential pattern. This is the fraction of the canister that you use per hour. These are unpublished observations, but we have been measuring canister life for the last 4 years. Again, we presented this at a meeting 1 and 2 years ago. So this is the fraction of a canister you use per minute here. So you use about 9% of a canister per hour here at 40 minutes, for example. And then, of course, you know the cost of the canister. You can easily calculate how much the canister costs. So here the cost of the canister with a CO2 production of about 160 is, I think, about 1.8 euros or something. Towards the end of the case, you want to anticipate that the patient is going to have to wake up. You give a small bolus of opioids. You check your neuromuscular block, and I start to coast. And what is coasting? You maintain a low flow, but you switch off the vaporizer, but leave the nitrous oxide on. Andre talked about this last year. Because the flow is low, there is no washout, but the end-tidal CV will still decrease due to redistribution. And what you want to get is, towards the end, an end-expired sevoflurane concentration of slightly lower than 0.35 MAC. Remember, if together with the nitrous oxide, that is still 0.95 MAC. When you're going towards the last stitches, you would want to switch off the nitrous oxide and increase the phase gas flow. And because the nitrous oxide washout is so fast, you'll get a very, very rapid wake-up. And what is coasting, so you'll let the end-tidal concentration decrease slightly to 0.35 MAC here. This is 0.35 MAC towards the end of the case. You're here. You want to make sure you give a small amount of opioid, because this will actually keep you above this line here. The patient will move. There will be no coughing on the endotracheal tube. And also over this dose range, the opioid will not have an effect on the partial pressure that keeps the patient unconscious. If you then switch off the nitrous oxide, you will drop within 2-3 minutes all the way here. So you're well below the MAC awake. This is the line that connects. This tells you that the effect of sevoflurane with fentanyl combined is such that more than 50% of the patients will wake up when you're below this line. So your patients will wake up very fast. Ask the residents I'm working with, within 2.5 to 4 minutes, regardless of the duration of the case, they wake up. How does this, so what I've been showing you now is pieces of the puzzle. I've brought together several techniques and understandings, and now let's see, so I tried to get the most out of the machine. Let's now see how that translates into anesthetic agent usage. So this is time, and this is milliliters of liquid sevoflurane. Look at these here. The average sevoflurane usage per hour is 2.87 milliliters per hour. There are some outliers here. What is this? Well, this is an instance where I changed the CO2 canister. And when you do that, when you replace the CO2 canister, the machine increases the fresh gas flow. And of course, this will prompt the machine to deliver more sevoflurane. So if you have somewhat increased FiCO2 towards the end of the case, don't replace the canister, do it in between cases. And this is the effect of changing your inspired oxygen concentration. Again, oxygen is very important. The machine will start using high phase gas flow to get there really fast. Remember, at the beginning I said if you give a high phase gas flow for about 3 minutes, you use 5.3 milliliters Sevo. If you do that before intubation, it's the same amount that allows you to give you anesthesia for 2 hours. The amount of sulfentanyl here expressed in milliliters, because that's what I need to calculate costs. It's about 7 milliliters of sulfentanyl. So now let's translate it into costs, and these are the last 2 slides. Here you have my IV drugs, my gases and anesthetic agent, and CO2 absorbent, with the costs and the amount that I used. And you see, if you add it up, this is what we pay for each of these products. I end up with 7.73 euros. So I don't get there with 4 euros, but 7.73 euros actually covers the cost of the entire anesthetic. If I look at an extra hour of maintenance, it will cost me 4.87%. And percentage-wise, the cost will be split evenly between your muscle relaxants, your inhaled agents, and actually your CO2 absorbent may become more expensive, relatively speaking. Look here, we're talking about 4.87 euros. So I think this really raised my point. Don't ask what your anesthesia machine can do for you, but what you can do for your anesthesia machine. If you really understand the different little details and merge them together, it's possible to really give good anesthesia with, how did I say it? It's not going to be the 4 euro perfect anesthetic, but it's going to be the less than 8 euro perfect anesthetic and the less than 5 euro anesthetic during maintenance. Thank you.